Welcome to the Rehab and Performance Lab, the MedBridge podcast where we dive into the world of orthopedics and sports. We're here to unpack the big topics, offering you practical insights and valuable tips from some of the most inspiring professionals in our field. Don't forget to visit medbridge.com to get your continuing education credit for this episode, plus access bonus resources. Hey everyone, welcome to the podcast. I'm Phil Plisky, your host. I'm a professor, an author at philplisky.com, as well as a performance systems consultant in professional sports. Being a physical therapist, an athletic trainer, and strength and conditioning coach, we come at this from many different perspectives. We want to provide the latest evidence, the latest research, but more importantly, we want this to be practical and useful that you can implement into your practice right away. I'm looking forward to today's topic, unseen forces, contextual factors that you may have had no idea were affecting your outcomes. I'm joined by Dr. Elizabeth Lane. She currently holds a research faculty position at the University of Utah. She has her PhD. She has her board specialty. She's a fellow in manual therapy, tons of different backgrounds, great expertise. Welcome to the podcast, Elizabeth.
Wow. Thanks so much for having me.
Fantastic. To get us started, could you give us a little bit about your background so people can get to know you?
Absolutely. Especially in context of this topic, I think I should mention that I went to undergrad at Auburn University and I majored in psychology. So I had a really strong interest in human nature. And then I did my physical therapy at the Medical College of Georgia in Augusta, Georgia. And even early in my clinical practice and internships, manual therapy just seemed like magic to me. And so I went into a residency program and then fellowship in manual therapy, and really have been just trying to fill the gaps in the variability of our outcomes. Why does this patient do really well and this patient doesn't do as well? And then this therapist is really awesome, and then this therapist is doing essentially the same things, but doesn't have quite as good outcomes. So trying to fill those gaps with some of these contextual factors has been super interesting.
Fantastic. So you'd mentioned to me that there was a time in your career where a light bulb just kind of went off for you. Can you describe that for me when you really kind of started to notice that difference between therapists?
Yeah, absolutely. So I after residency training, I moved clinics and I started practicing with this clinician who's OCS trained. And she just had this way with patients, and everybody loved her, and her outcomes were amazing. We ended up doing some manual therapy certifications together, and so we had this awesome environment of practice. And the thing that I really picked up that from her that changed my practice completely was these contextual factors. And I didn't know what they were called then, but it was like this it factor that this therapist had. And she had amazing outcomes and just such an amazing person. And so now I took a lot of that and stole it and made it my own. And now we're getting some names to some of these factors that were having a big impact on our outcomes in that clinic. So it's really, really cool.
So that's our topic today, is contextual factors. So can you define what those are? What is a contextual factor? Because I always say one of the things I've gotten away with, the most common answer in physical therapist education, athletic trainer education, when given any question, we always get the "it depends" factor. It depends, and I actually like to say context matters, and let's give it a little more context. So I don't use that anymore. How would you define what contextual factors are for everybody?
Yeah, my students will laugh at that because that's one of our biggest phrases, and I don't leave it as it depends and further define that, but they will especially appreciate that. So our contextual factors are everything outside of our specific intervention. So it is our components of our therapeutic encounter that may constitute the entirety of those perceived effects, or it is additive to the effects of the intervention. And so it's kind of the other, those unseen forces is what we're calling it for the topic of this podcast. But it goes by some other names: our placebo effect, contextual factors, common factors, so things that are common to lots of different treatments, and non-specific effects could all be considered contextual factors.
So why is this important to talk about? I mean, we know each patient is a little bit different and things like that, but so what?
Yeah. So if we think about the specific effects, what our particular manual therapy intervention is doing or exercise intervention is doing, we previously thought that that constituted maybe most of our outcome. And then there's a little bit of this contextual factors. Well, this year in JOSPT, it was studied on how much are contextual factors playing a part of your outcomes. So for manual therapy, as an outcome for pain, 88% of the outcome was explained by contextual factors, not the specific manual intervention. For exercise therapy, it is 46%. And this is not just a thing that we study in physical therapy or that affects our physical therapy outcomes. It's also been studied in NEOA. And so, for example, NSAIDs contextual factors account for 70% of the outcome in NSAIDs, 85 for topical NSAIDs, lavage. So just going in and cleaning out the joint, 91% of that outcome is explained by contextual factors. So, maybe if it was a small piece of our outcomes, we could say, I'm not really that worried about it. But when it's the majority of your outcome, then you really need to be aware that they're there. And we need to think about, are there ways that we can leverage this to help our patients?
I've got to pause there for a second. This is amazing and interesting to me. So you're trying to say that the research is saying that in our manual therapy interventions, one of our bread and butter type of things, or I really kind of feel like there can be really polarized camps in rehabilitation where manual therapy is everything or exercise is everything. We know that's probably the truth is somewhere in the middle. But you're saying for a manual therapy intervention, 88% for pain reduction, 88% of it is explained by contextual factors. Can you give me an example of that? Can you give me either a hypothetical scenario or something that I can, because that's 88% seems like a lot to me being explained by contextual factors, not by the treatment itself.
Yeah. So to give an example, we have to talk about maybe our broad categories of contextual factors. So our categories of contextual factors include patient factors. So maybe patient beliefs, our therapist factors. So how confidently do you come across the interaction between our patient and therapist, the environment, and then the nature of our intervention. So to provide an example, if we think about a very kind of rote type of intervention preface given to a patient, this intervention, we're really not sure how it can affect your outcomes, but it's known to help some people, versus an enhanced type of interaction. Based on what I see in your exam, Susie, and what you're telling me about how you extend and you have some pain in your lower back and that travels to your hip, then what I've seen in practice before and what the research tells us is that you're going to do very well with what we call a lumbar manipulation. It's just a quick stretch that we provide to your low back. And the differences in the preface of how we approach that patient, no, even if we do the same exact intervention, Susie, who I've mentioned, and we can talk about these things a little bit later on, like how we're targeting those things, is going to do much better with that intervention than this kind of evidence to like a rote type of intervention.
So I hear from this, we call this in a lot of different terms, people skills. In professional baseball, they call it feel. It's kind of a funny concept, but it is this idea of that interaction with the patient. How is this different or similar than maybe the therapeutic alliance concept that we hear a lot about?
Yeah, therapeutic alliance has the strongest effect on our contextual factors. So the broad categories I talked about before, the patient therapist interaction would be our therapeutic alliance. And we have some information from some researchers who tried to quantify what contextual factors have the biggest effect. And we think about therapeutic alliance being really kind of three components are, how much does the patient like you? As rehab providers, we kind of max out that scale. Like our patients really like us.
Right.
And then the other two that we could probably use a little work are agreement on tasks and agreement on goals. So that being our therapeutic alliance, then those three components really play a huge part in these contextual factors.
So therapeutic alliance is essentially one subcategory of contextual factors. So
Absolutely.
they're not similar. So therapeutic alliance is a subcategory of it. Now you mentioned two areas of therapeutic alliance that maybe were not as good on at that. Can you elaborate on that a little bit?
Yeah. So our agreement on goals. So this is not, hey, what are your goals for physical therapy?
Yeah,
This
standard
is,
question. That's the standard
yeah,
PT 101
that's not really,
question.
maybe that's not the best way to get at what a patient truly values. When you ask them, how can I help? What are they saying, right? Are they saying, hey, I really want to be able to do this? And many patients, if you ask about goals, they go to a pain goal and just say, well, I'd really like to have no pain.
Mm,
Yeah, that would be great. But can we provide some more context to that? And, well, if you had no pain, what would you do? Right? So you're tying it back to function, and then you're constantly through your interaction with that patient, you're constantly talking about their goals, and that's closely related to tasks. So agreement on tasks is that second one that we could do a little bit better. And I talk to my students about this all the time in residence, that you're constant, like I'm all in your face about, hey, I need you to justify why you're doing this intervention with this patient. And
mhm.
so you're going through this process and like, oh, they really want to get back to hiking. Okay, so I'm going to have them do some stair climbing. Maybe they're not ready for that. I'm going to have them do some bridging because I want to get their glute activation up. And all of that's going on in your head. And that makes a perfect that's a great line of thinking to get them back
Sure.
to hiking. But if you're not letting the patient know, hey, I'm doing bridging because of this, it's going to get you to this and get you to this, then all of that's lost, right? Like, or you're not leveraging it the way you could. And that way the patient's like, oh, they really heard me that I want to get back to hiking. And this exercise is going to help me get back to that. And so those agreement on tasks, letting them know your clinical reasoning can really be helpful.
So that's really interesting to me because as we look at it, one of the things, sometimes we do a lot with regard to movement analysis and basic things. We're in low back pain. We're working on the transverse abdominis. We're working on the multifidus. Maybe we're doing a manipulation and things like that. And that doesn't necessarily have anything to do with playing baseball or hiking or picking up my kid out of the bathtub, right? And so you're saying that we actually should explain our connection because we're trained. I mean, we spend a lot of time, learning how to deconstruct activities so that we can get to to where the root of the problem is and then build from there. But you're saying, I think sometimes we're so taught to demedicalize everything and don't use medical jargon, and that's part of therapeutic alliance and is a huge part of it. But the flip side of that coin is, though, you still have to explain your thought process kind of from beginning to end a little bit.
Absolutely. And I love that you're mentioning, like, hey, we're getting away from medical jargon. Yes, that does harm our therapeutic alliance, and it may be harmful for our patient expectations, which is another huge part of contextual factors. And it doesn't mean that you have to explain the transverse abdominis and or explain this manipulation and what's happening neurophysiologically. Patients don't really hear that very often, right? There might be a specific subset that do, but all we're explaining is like, hey, I see these factors in you. When we've seen this, the research and my clinical experience are telling me that this intervention is going to be helpful for you to improve this motion, which is related to the activity that you want to get back to. And the journey that you're walking them along, it can be so helpful just to help them understand. And you don't have to use any fancy words to explain that. In fact, the more simply you can and concisely you can explain it, the better it's going to be understood by those patients.
That's fantastic. So a lot of this has, does the research tell us anything about the characteristics of providers that the providers, what does it look like in a contextual factor perspective? What characteristics do providers have?
Yeah. So experience out the window. So that's great, right? The experience is not necessarily something that you need. New grads, student physical therapists can leverage these just like anyone else.
I see
It
that actually
is
often in the case where on clinicals, I see frequently that students are requested over the experienced therapist.
that's
Do you think
amazing.
that's a contextual factor there that is coming into play because the student really cares a lot, is really passionate, and has almost no expertise?
Absolutely. Yeah. So if we're thinking about if we're going to define this by our therapeutic alliance, then we need to make sure that they know we care, right? So I'm going to remember the things that they've told me that matter to them. The other thing is being confident. It's not ever saying that I don't know. It's saying that you can say, I'm not sure. I will find out for you if there's something that you need to research. That doesn't harm your therapeutic alliance necessarily to say that. It is explaining things in a way that patients can understand. So just using simple language, concise and clear language can really help that therapeutic alliance and help your leverage your contextual factors.
That's awesome. That's awesome. So, can we walk through, like how we see this playing out in a therapy session? Like, what does this look like if we use this clinically?
Yeah, so let's start with your subjective examination. Okay, so a thorough subjective examination in itself has been shown to reduce pain in patients.
Hmm.
So they did a study with patients with back and leg pain and showed not quite an MCID in their pain reduction, but 1.5
Wow, right
on
there.
our NPRS scale
Right.
just by doing a proper subjective examination. So, listening to the patient, right? Making sure that the patient feels heard, that you're not interrupting them, that, they get a chance to tell their story. So, first off, going through a proper subjective examination is huge. And then with their objective examination, you'll hear from patients all the time that say, I went to my doctor and they didn't touch me at all.
Mm.
So doing a proper objective examination, explaining that process along the way so that they know what to expect is actually a huge thing. So we're going to talk for a little bit. We're going to do some objective exams. I'm looking for things that make your pain squeak, is what I normally say. Once we find that squeaker, then we're going to match what we found in your with an intervention. And so as I get done with my objective exam, I'm going to
So,
lay it out.
are there questions that you like? You say, I never miss asking these questions in my historical portion of my exam. Like, are there things that you want to be sure that are just, I don't know, I don't want to say guarantee that therapeutic alliance, but really kind of drive it home?
I would say it's not a question. It is more of the process. So at
Mm.
the end of the subjective exam, I'll give a bit of a summary. Hey, I want to just make sure I got all this right. So you have this problem area. These are the aggravating and easing factors for that. Once problem area 1 gets so bad, then problem area 2 will start. It ranges between this and this. And so I just give a summary of the subjective examination, and that gives them a chance to correct me on anything that I misheard. And then it lets them also know that I was really listening to all of these
Yeah.
things. And they're like, wow, yeah, you explained it way better than I did.
That's awesome. That's awesome. Okay, so when we are now, we've gathered our data, right? We've done a historical examination, we've done a physical examination, we've gotten those squeaky things to squeak, and now we're talking to the patient. What does that look like?
Yeah. So this is the part where your assessment, right? Your A of your SOAP note kind of thing is that, hey, here's what you told me. Here's what I found in my exam. And I don't have to give them a pathoanatomical diagnosis at that point. In fact, I generally shy away from a pathoanatomical diagnosis. Your nervous system is sensitive to this, this, and this. When we see that, this intervention has done really well. Do you have any questions about that intervention if it wasn't clear on what it was? And then we're going to say, now, as we do this intervention, we're going to come back and test these 3 things that squeaked in your objective exam and make sure that those are showing some improvement, or if we need to change that intervention there. One thing I should mention from the subjective exam is I try to get some information about their expectations. Mm-hmm. So not, do you have any expectations for physical therapy, or have you been to physical therapy before? But what they expect is going on with what they believe is going on with their situation, and that might be helpful. And I've had that asked to me in some ways that I thought were very well done. And it goes like this, to give you some language. Many times patients have a sense of what is going on with their body and what would help. Do you have a sense for what's going on and what you think may help your situation or condition? So that was given to me by a physician, and I thought that was really.
I love the way you say that too. Like, many people have this. Do you have the, like it's empowering, that's very empowering language to be able to say, hey, I value what you think is going on, because I think Syriacs actually said it, a father of orthopedic medicine, said a long time ago, is listen to your patients. They will tell you how to treat them, and that doesn't take away from I think sometimes people feel that takes away from our expertise. I use it as, this person has lived with themselves with this condition for so long that they might notice things that aggravate it, make it better, or have a belief that they need to be treated in a certain way that it become important. And I need to do one of 2 things. I need to pay attention to that. And if my treatment is going to align with that belief, we're going to maximize that. It kind of, the language you used in the beginning here is like, hey, I've seen patients with this before. The research says this is going to go well. Actually, I think you've already kind of noticed that yourself, so we're going to go down that road. But then also, it's probably important. Can you give me some language when the patient's belief of what's going to help them does not align with maybe what I know from the research or how they're presenting? Can you talk to me about how you would talk to that patient?
Yeah, and that's a very delicate balance in talking to that patient and getting some idea of their beliefs beforehand and how cemented they are in their beliefs can help you. So if you ask that question and they say, well, I have a herniated disc and really the only thing that I feel like is going to help me is surgery, mm-hmm. then I may take a very different route in my education. And if they have very strong beliefs, then it may not be worth the squeeze for me to try to change those beliefs, mm-hmm. especially not in one visit. Right. If they have, beliefs that are a little bit more malleable, like, I don't know, I just know that when I do this, it really hurts. Then we may just say, yeah, your nervous system is sensitive to that extension moment. And we've seen this before. And what we found in your exam is that when I shift you to the side, that pain in your leg reduces. It does get worse in your back. I understand that. And I want you to let you know that that's okay. That's actually what we're looking for. So that's great. The fact that we can get it out of your leg tells me, and from the research, that you're going to do really well with physical therapy.
That's fantastic. One of the things I want to point out there that you said, and kind of draw it out a little bit, is let's take that patient, that hypothetical patient who is coming in because their insurance company is requiring them to have physical therapy before they can consider surgery, right? And you're talking to them, they're like, they're using language like, I have to be here because I can't get surgery until I do this first, and all those kind of beliefs that are I mean, pretty legitimate that they would have those, right? I mean, because they haven't been educated on it. And I think sometimes I see, probably was guilty of this early on in my career, where I would like beat them over the head with the research club. I would say, you're right. It's like, well, the research says that, disc bulges, there's, in 100 asymptomatic people, 43% of them your age are going to have a disc bulge. And I'm going to go through and beat them up with statistics that way. Um, Now, there's probably a time and a place for that, but it's probably not right out of the gate, and it's getting a little bit more therapeutic alliance first. Would you agree with that?
Absolutely. If you think about beliefs, the things you believe, right? Or the things that people in society believe, if you're going to try to change those beliefs, they need to trust you, right?
Yeah.
Like, who are you to come in and tell me that this is wrong? And we also know, just to be careful about the language that we're using with patients. And if they've been around the healthcare provider block a few times, then they've heard maybe 4, 5, 6 different diagnoses for what they have. And so I don't want to give them another diagnosis. I want to understand what they've heard previously, and I want to try to marry that together. Hey, I know that you heard these few things. Those several things are really the same words, or the words for this same condition that I'm talking to you about. And so we can help remove some of that ambiguity for them. But yeah, you're right. If we're going to try to change someone's beliefs, we better have a good relationship with them first,
That
or you're going to have
relationship is
no relationship
first.
with
we
them.
we you, in leadership training, we talk about, before you can really provide any critical feedback, you have to have your arm around the person, metaphorically or physically, first. Meaning, in order for them to receive that feedback, they have to trust that you have their best interest at heart, and you really actually need to do that. You can't just fake that either. Like, that's an important concept here.
No, they don't care what you know until they know you care, right?
Absolutely. So you have used words that kind of lead me to hearing some pain neuroscience education. Tell me how, if we say that our therapeutic alliance is a subcategory of contextual factors, where does pain neuroscience education kind of fit into this realm here?
Well, pain neuroscience education fits in multiple areas. If we think about it as an intervention, well, we have to think about it as an intervention, but we also have to think about those patients' beliefs and expectations. So if we're going to try to change what they believe, number one, they may not need a lot of changing the beliefs from one direction to the other. They may already be kind of in the middle. Hey, I'm not really sure how pain is processed. I have like this rudimentary idea, and very open to what you have to say to them. And then that person on the other end we talked about before, who has very strong beliefs about what is going on, then we're going to have to use some more motivational interviewing type of techniques, asking permission. Well, I understand that you believe that this herniated disc is really what's causing your pain. I've had some other patients who have thought that before, and we were able to share with them some different ideas of what may be playing a part of their pain. Would you mind if I share that with you? And so we have to come at this pretty delicately with that patient. But our pain neuroscience education can shape that patient's expectations, right? And those patient characteristics, which were one of those contextual factors. If they're expecting that they're making things worse when they have pain, then then we've got to really educate that, hey, it's not that you're making things worse. Your nervous system is just sensitive. So this is not harming you. It's not that we're going to repeatedly press that pain button, but we just have to shift your mindset on what pain means.
Okay. So now with that, I always, one of the things I think it's big, you brought up several different points here, everything from, getting the patients, aligning patient goals, aligning tasks, doing comparable signs in a retest model. I always ask, when we're talking about, this pain neuroscience education, what does the research tell us about matching that education to the right person? Meaning, if we think about, we know there are patient types, certain patient factors that make them more likely to benefit from manipulation versus, direction specific exercise. And we have these factors. What do we know in the pain neuroscience education field about what are those factors that may be that can cause us to say, hey, this person maybe needs a little more or potentially a little less neuroscience education?
Yeah, that's the $1 million question right now in the P&E research, that I wish we knew. So I don't have any evidence to tell you on like which factors are going to produce better results with P&E. Theoretically, we would say that those patients who have more central sensitization probably need some more P&E, and other psychosocial factors like decreased self-efficacy, increased catastrophizing, or
Okay.
increased fear of movement probably would demonstrate the most improvements from P&E, but we just don't know yet.
We don't fully know, and one of the things that I think, and again, I still remember myself, it actually continues today, that, when you go to a continuing education course, suddenly that every patient needs whatever thing you learned that weekend. And I'm afraid maybe the same thing has happened with, neuroscience pain education, is that we almost come across with every patient needs that. But what I'm hearing is maybe not every patient, and maybe each patient to a different degree, depending where they're at.
Yeah, I would agree with that, just to a different degree. Like someone who comes in with a very acute injury, it's very nociceptive in nature, and they have very low psychosocial risk factors. Our our current TBC would say, you need to evaluate that patient, and provide them with some education, and then they can go on their way. That we don't even need formal treatment for that patient because they're at so low risk of developing persistent symptoms. Maybe part of that education is, hey, by the way, back pain doesn't mean that something serious is going on, which is a touch of P&E, right? Like that
Right.
that our pain doesn't equal, our input doesn't equal pain, our output. So I would say, I almost want to throw in a little prophylactic, like, hey, just want to let you know that like everything is sensitive right now, kind of like a sunburn would be, but things are going to improve to a point, and it doesn't, persistent pain doesn't mean that something is going wrong in the case that may happen. But
I've never heard the sunburn analogy. I
oh,
really like that. I
that's
really
great.
like that because it can be really painful, yet at the same time, it hasn't caused this awful, damage, per se, unless it's super, super bad. And in that
Right.
case, we also know that with your musculoskeletal system.
Yeah. I mean, you get a sunburn and you get in the shower, you know that the water is not harming you, but yet it hurts, right?
Oh, I love
Yeah.
that. That's fantastic. So let's talk about, so if we put this all together, can you help me categorize underneath in everything that we've talked about? Can you help me categorize underneath these contextual factors the different things that fit in there? We've talked about therapeutic alliance, we've talked about P&E, we've talked about goals and all that. Tell me how those interplay with each other.
Hmm. So, if we talk about, let's start at the top with our patient expectations, and for our patient characteristics, sorry, which would fall into that patient expectations. So many patients' expectations are malleable. So let me just give one research example. So this was ultrasound for chronic low back pain. We know that ultrasound for chronic low back pain, per our CPG, we probably should not be using that.
Right.
But they had, this is from Adrian Lowe in 2016. And so they had an ultrasound control group, just doing ultrasound. Here's what ultrasound does. It increases some warmth and blood flow. And we normally do this in a figure 8 pattern. And then they had an inflated group. Hey, we're going to do some clockwise ultrasound for your back pain. And this has been shown to help chronic low back pain. And then they had an extra inflated group. So this is what ultrasound does. It's normally done in a clockwise fashion, but for your back pain, there's some new research that says we're going to do it in a clockwise format for you. And so and it's been shown to help your straight leg raise go a little bit further, the test that we did earlier. And in the outcomes, this straight leg raise was more likely to improve in the extra inflated group. So those are patient characteristics, expectations. And there's many studies that look at that. And that's so cool to me. Like, just you're doing the same thing, but it's just what you're saying beforehand that makes the difference in the outcome. So that's really, really cool. And it's not just placebo effects, that they're just fluffy and cloudy kind of outcomes. It has also been shown to have improvements in pro-inflammatory cytokines by having an expectation provided, which is cool, right? That's a physiologic, this is changed between this group and this group just by the words I said.
I love that. But it makes me wonder if we started this episode talking about the research that says maybe 88% of what we do from a manual therapy perspective is contextual factors. Do I even need to have good hands-on skills?
Okay, so I spent so many years making my hands really, really good. And I don't know that that's true, that you really have to have your hands really, really good, and really, really specific maybe more of the thing than having confidence in your hands. Because if you've had a skilled clinician touch you and then not a novice clinician touch you, there's a difference in the confidence that you can feel when they touch you. So it may not really be that the technique is that much better, but the confidence that they portray with their hands, in my mind, does matter. And I don't know that that holds true in the research.
So could it be, and this is pure conjecture, pure speculation here, that these contextual factors maybe just aren't measuring these factors outside of the clinician? And I know we talk about factors inside of the clinician as well, but is it possible that there is some carryover, or there's some cross contamination, if you will, in that what you just said? A skilled manual therapist is going to have confidence not only about what they're finding, but about how it's going to work and how they're going to apply it. And that is actually a contextual factor, so it can't be diminished.
No, absolutely cannot be diminished. Yeah, that is what we're talking about, right? And that was the difference between me and that therapist that was so good at talking to patients and explaining things that I worked with.
Okay, so because I think that's where a lot of the even the P&E education or therapeutic alliance is just saying, I think people interpret that and going, well, if I'm just a really high quality individual who cares about people, I could actually do the worst interventions and still get people a lot better. And that is probably true. But really, we're not talking about bad medicine being your foundation. We're talking about good medicine being accelerated by being a good interpersonal skills.
Absolutely. And I normally preface the word placebo with that. Hey, we're not trying to sell snake oil to patients and we're just tricking all of them into thinking that they're better. Absolutely not. Physical therapy works, right? And there are specific effects that from our interventions, and all we're doing is making those better.
That's awesome. That's awesome. All right. So if we talk about, what is the biggest impact, if people are walking away from this and you're like, man, if they could just hear 3 things from me that they could start doing that would change their practice this week, what would you say those are?
I would say understanding patient goals. So agreement on goals. And that again is not the question, hey, what are your goals for physical therapy? It's understanding what they need to get back to. That may be an introduction of it, but goal consensus, actually this was studied in 2016. So what are the biggest bang for your buck contextual factors? Goal consensus had a 0.7 effect size. So definitely goal consensus. The next that I feel like we already do really well at is empathy, and that had a 0.6 effect size. So we definitely need to be empathizing with our patients. You can't just show up for your job and that happen, right? You're invested in your patients. They know you care. And then alliance. And so that's all three factors had a 0.59 effect size. So that would be the last part of that alliance would be agreement on tasks. So let that patient know why you've chosen this intervention, how that's going to help them get back to their goals. And then you've maxed out all three parts of that therapeutic alliance.
That's fantastic. All right. I want to ask a final question here as we wrap things up. If you were to go back and go back into time and you're that clinician in your first, 0 to 5 years, what advice would you give yourself?
I think I would go about things pretty much the same way that I have. I was really lucky to be in the clinic with this therapist and then take the journey that I have. And I feel like because I didn't understand all of those contextual factors, that I now understand them better because I had to try to figure them out on my own. Sure, it would have been nice for somebody to tell me, hey, especially during residency when I'm just drowning in this evidence
Right.
part of evidence-based practice, hey, it's probably okay to just spend a lot more time talking to your patients and getting better at doing that.
Which is, by the way, why most of us got into rehabilitation anyway.
Absolutely. Yeah. For those relationships and taking that patient through the journey one step at a time. Yeah. But I think it would just be, there's a lot that you can do without beating yourself up over knowing the evidence and your hands-on skills. Not to say that those aren't important. I think that they are important, but there's a lot more out there.
That's awesome. And one thing I really actually hear in that, in your entire frame of your entire clinical journey and your education journey, is the importance of a high quality mentor. Someone who is, I have a feeling that I don't want to put words in your mouth, but I have a feeling that the people you were under loved rehabilitation, loved physical therapy, and loved their patients. And you saw that, and that seemed to be motivating to you.
You're absolutely right. And, not all people have that opportunity. And, if you just, I'm going to throw out a suggestion that many people are going to shy away from, but if you just record your patient interactions and go back and watch those, you will be so enlightened as to, what your body language said, what your language actually said, what the patient was telling you. I did this during fellowship and I was like, oh my gosh, I asked that patient the question. They didn't answer anything about what I was asking. And I just went on. I was like, what was I even doing there? So.
That's incredible. Yeah, absolutely. I love that advice. I mean, we do that actually for communication training and becoming a better speaker, that, until you see yourself recorded in video, and we all hate that, but man,
Yep.
that's a great way to do it, even as a clinician. And we're definitely going to tuck that one away. And I hope people actually implement that. So,
Me too.
well, that's all the time we have. For more information, be sure to check out Elizabeth's courses on clinical practice guidelines for hamstring tendinopathy, low back pain, and of course, contextual factors, because she's an expert there. Thank you so much for being with us today, Elizabeth.
Oh, Phil, thank you so much.
Fantastic. Well, you can find out more information on what I'm up to and what I'm learning at philplisky.com. And until next time, let's keep building the future of rehabilitation and performance together. Thank you for tuning into this episode of Rehab and Performance Lab by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform, and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Rehab and Performance Lab also listens to you. If there's a particular clinician that you'd like to hear from, Or if you have a clinical question or a challenge that you would like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com. See you next time.